Hey everyone, welcome to Folds and Curves. I'm your host, Mokash Kush. Today's guest is Sam Bott. Sam is a pharmacist, and he's also someone that was in pharmacy school a few years ahead of me, so I know him from school. And Sam was actually one of the people who introduced me to the biotech industry and got me interested in it in the first place. And that's because him and some other colleagues started a biotech investment fantasy league in school where you basically made up a portfolio of biotech companies, and whoever had the best performing portfolio won some prizes. And I really enjoyed this. It really was educational more so than just about having the highest returns in your portfolio. I thought it was really educational and was my first foray into learning about the future of medicine, as people often say. But yeah, aside from that part of Sam, which makes him really interesting in that respect, he just really understands the market. And so one example of that is his last job, which is where he was a consultant at IQVIA working on market access strategy. And that's the focus of today's interview. Although he's also currently a medical outcomes liaison at Akebia Therapeutics, which is a pretty interesting company working on anemia for CKD. And they have some pretty interesting therapies in the pipeline for that. So without further ado, let's get started. Please check out the show notes for the relevant links for Sam. Okay, Sam, thanks for joining me. Let's just jump right in. I wanted to get your take on what the term market access means in pharma.
Yeah, absolutely. And thanks for having me, Mo. This is a really cool podcast. So thanks again for having me. So
Thanks.
market access is a pretty strange term. And I think it's one of those terms where if you ask, 10 people what it is, you're going to get 10 different answers because it's just kind of this ever evolving field in the space. So what it means to me is essentially, if you boil it down, it's just reducing any barriers for patients to get onto therapy. And that's kind of like the simplistic terms of what it means. If you ask other people what it means, they may say, it's something to do with insurance. We're going to deal with like formularies. We're going to deal with copay cards. We're going to deal with patient assistance programs. But like, if you boil all of those programs down, if you look at formularies, patient access programs, getting HCPs to understand what the drug is all about, what you're doing at the end of the day is just making it easier for patients to get onto therapy, be it, cheaper costs for their insurance or cheaper costs to the pharmacy. That's what it all boils down to.
Okay. Yeah, that makes sense. So that's sort of like the overarching goal is to get patients on therapy easier. I think you mentioned some of the like ways in which that's done. And I guess formularies in hospitals, is this fall under the umbrella of market access?
So it totally does. I think that, again, if you talk to different people, some people would say, like insurance companies, PBMs, payers, like those are in our wheelhouse. And they don't really look at these other areas. But I think what you'll find is these other more like obscure areas of access are definitely growing in the space. So, particularly in the IDN space, so integrated delivery networks, they're going to have their own ways of looking at how to manage drug. And to your point with like hospital formularies, it's one of those areas that I don't think companies really put enough focus into sometimes. But that's an area where these people are going to have to make decisions on what drugs to use for patients. And ultimately, if you can provide them with the education necessary, if you can get in there and get the deals to work to make it favorable for them to be able to use your product, that's an area of access that definitely needs to be addressed. And so, yeah, definitely, hospital formularies do touch into that market access space.
Okay. Okay, great. So, I guess I imagine that this sort of is where value and health outcomes sort of falls into the market access area. I don't actually know what IDNs are. Is that like health systems, basically, like large health systems, or is it different from that?
Yeah. I mean, you can think of, right in your own backyard. UPMC is kind of a pretty famous IDN, just because they've kind of, captured all the different sections of the market, going all the way from, having patients in the hospital to the care delivery in the outpatient setting to the pharmacy to the health, the health insurance. They have health like UPMC health plan. So you have all these different aspects that are going on in this health ecosystem. And if you can kind of control all of those, you're, for the most part, an IDN.
Yeah. So how do these IDNs sort of make decisions regarding what drugs they want their patients on, and what drugs that they want at certain prioritizations and at lower priorities? Can you just kind of give some insight into how these IDNs think about the value of a drug, and how much they want to pay for it, and if they want to use it at all?
Yeah, that's a good question. So I think, again, it's one of those things of, depending on what IDN you're talking to, you're going to get a different answer. And some of them might not want to tell you what their answer is for the sole fact that it's money. So if you look at the spectrum, you're going to get people on that spectrum that care a lot about the money. So, they're going to be really focused on their bottom line and what drug we can get for the cheapest that does the job that it intends to do. Somewhere in the middle, you're going to get people that are going to make the decisions mostly based off of money, but then they're going to look at the clinical aspect and say, what's the cost benefit of this? Are we getting the clinical outcomes that we want for the money that we're paying? On the far side, you might even get a few unicorns of IDNs and other sort of like health payers out there that make decisions more based off of the clinical outcomes you get. And, when I say unicorns, like, these people are not typically common. A lot of what you'll find is kind of like a bell curve look for the spectrum going on, where like a lot of people are in the middle, where they're making decisions based off both, money and the outcomes that you're going to get. And that's really where that HEOR, or health economics and outcomes research, that's really where that falls in, and why it's so valuable to these health systems, because they use that information to be able to prioritize what drugs you have, what works best. And so that's kind of how decisions are made in there. And that like really oversimplifies things. I want to point that out as well. It's a very complicated process. And a lot of times it takes months and months and months to decide. So I don't want to give the air that it's a very simplistic process, but that's kind of how they make decisions there.
Gotcha. And so I guess, like, what makes it more complicated? Is it just that there's not black and white answers and it requires like really thoughtful analysis, or is there some sort of bureaucracy and difficulty in actually reaching the right people to get the information across? Maybe a little bit of both.
Yeah, I mean, definitely both. So, I mean, if you think about, a health system, or you can, in this example, just like a hospital, trying to figure out, what drugs they want to use, you have to think to yourself that, it's not just one drug in there, right? We're looking at a couple of different drugs, and that's like probably a small class that we're thinking of here. So if you're going to take the time to evaluate all of these different therapies, you have to have people dedicated to doing that. Or you have to, work with some sort of consulting firm, or you have to work with the company to get the data that you want to get. Once you get to the point where you actually can get the data, which kind of takes some time to get all that data straightened out, then you have to evaluate it. And so you're going to have to go through like pharmacy and therapeutics groups, or P&T groups, as you'll hear them pretty frequently. So it's basically like the formulary decision makers of the hospital or the IDN. And so that can be its own process where, you go through, you talk about it, you start to make debates on either side of what's going to work, what's not going to work. You're going to have key stakeholders you have to consider as well. So, I mean, you can be a part of this P&T group and make these decisions, but if you, tell the physicians in your IDN or your hospital, this is what we're going to use, and 90% of them go, that's not what we want to use, these don't work on our patients, then, you've made a decision without even considering the key stakeholders of the system, which is not the best way to do it. So it's very much like an iterative process of working with your stakeholders, getting the data, analyzing it, working with the groups, and then implementing protocols and algorithms to be able to actually get these in the system and get them working. And particularly, now in the modern era where everything is digital, you have to work with like your electronic medical record. A lot of the times, if you're in a health system and you're a physician and you want to prescribe a certain drug, you might try to prescribe it online or through the system, and it'll tell you, that's not the right drug. our formulary preferred is actually this. And so you have to think that, after all this P&T gets pushed through, there has to be another team on the back end that's doing all the implementation for this information for, every class of drug out there that they're concerned about. So that's kind of why, these processes tend to take time. It's just because it's a lot of man hours, it's a lot of decisions to make, and there's a lot of stakeholders that can be, very angry if you don't make the right decisions.
Yeah.
And so that's, providers, patients, health insurers, it's an ecosystem when you break it down. So you got to make sure that everyone is at least agreeable. I don't think you're ever going to get to the point where everyone is happy, but you have to get to the point where everyone is at least agreeable.
Yeah. I'm really happy you brought up the implementation and like the electronic prescribing system aspect of it, because I think that's like one of those. It's an example of an often sort of forgotten thing, which is that everything in healthcare is difficult to implement. I mean, if you've ever worked with one of these systems, everything's trying to nudge you in one direction, and then you have like alert fatigue where you just kind of hit skip because it's alerting you too much, and it starts to lose its meaning. And it's like this complicated network of legitimate information technology and good safety measures, but also like these behavioral aspects that are just kind of difficult to plan ahead for. And you sort of just have to get the right kind of like Goldilocks of the not too much, not too little.
No, exactly.
Yeah. So I'm curious on a couple things, but I'll start with this. Like you mentioned, this data that you want to get. Is this data generated outside of sort of this like pivotal clinical trial that gets a drug approved? Are these kind of like other trials, not the main phase 3 large study, or can it be weaved into that? How does that normally look? I'm talking about health economics and outcomes research now. Is this post-marketing usually?
Yeah. So I think a lot of people tend to think that HEOR tends to be more like post-marketing. But what it really is kind of just through the life cycle of the product. And you kind of have like different studies that you tend to want to do at different phases in the product's life cycle. So, I think what we would be considering with more of like a formulary decision for like a hospital IDN, something like that, we're thinking more of that like peri-launch, post-launch phase, where you have a little bit of information about, what is this drug going to cost? What are the costs that we should consider? And how are these going to affect our system? So when we think about those sort of studies and trials and things like that, a lot of times they're going to look at sort of like the totality of the data. So they're going to look at those pivotal trials and they're going to consider those, but they're also going to want to consider any sort of, post hoc analyses that they can do. So a lot of the times companies will take, their pivotal phase 3 trial and they'll, look at the effects compared to whatever, other drug they compared it to, or they'll do some sort of a meta-analysis to understand, if we can get these outcomes, how much costs will we be saving compared to the competitor or the standard of care on the market. And so, once you get a chance to get the outcomes and assign costs to them, that's kind of like the data that you want to get there. And that's exactly what a hospital, IDN, payer, like literally any sort of, decision maker that has a formulary or a protocol or an algorithm, that's what they're going to use to be able to figure out, if we implement this drug and it gets this sort of market share in our hospital or in our system, is it going to be a net positive or is it going to be a net negative on our budget?
Okay, gotcha. So that's interesting. I've sort of just in my experience, I've heard sort of the economic argument for certain drugs, which is that it's not necessarily cheaper, but it can avoid some downstream surgery. It can maybe it reduces the likelihood of some terrible side effect that's super expensive to fix. And so therefore it's net positive on your budget because it'll reduce the amount of, readmissions or something like that. Do you find that payers are receptive to that kind of, I guess, logic where you pay more upfront for savings downstream, or is there more of like a short, I guess, short-term mindset among payers?
Yeah. So, I mean, before I give you my take on it, I'm going to kind of walk you through sort of like a historical precedent on this sort of thing. It might be something you're familiar with, but back in 2014, but Sovaldi launched for hepatitis C, and I think that is sort of like this golden child of like health economics and outcomes and research data, where they're able to cure disease and they're able to prevent future liver transplant and liver failure. So they have this very much like Goldilocks data to show you, with the idea that these are going to cost upwards of $100,000 per treatment. Right. So, what we can take away from that historical precedent ended up being that, payers were really receptive to it, but because they cost a lot up front, they really limited the implementation, because at the end of the day, they do only have a set pool of money to work with. Sure. And if they were to cure, every hepatitis C patient they had, they would all go bankrupt. So just things to keep in mind. And so I think with that being said, when we talk to payers, when we talk to PBMs, I think that, it really depends on who you've talked to in these organizations. They're not kind of this like monolithic organization. And this is kind of like an idea that I had in school, is that, United Health is just United Health. But really United Health is made up of, the spectrum of different people that work there, be it more, actuarial, business-minded people, or be it more like clinical advisor type people. And they all want to know about the drugs that are going to get added on to, the company's formulary. And so if you talk to, the clinical advisors that typically tend to be, physicians, like pharmacists, nurses, they're going to want to really care about that clinical aspect of it, the outcomes. And if you talk to more of the actuarial people, their first question is going to be, how much is this drug going to cost? How many patients are going to be on it per year? And so they're already doing that calculation in their mind of, how is this going to mess with our bottom line? How is this going to mess with our, per member per month cost? But the cool thing is that at the end of the day, when they're making decisions, they tend to make them together. So you have more of the business-minded actuarial people coming to the table. You have more of the clinical group coming into the table. They're all kind of debating that different aspect. And I would definitely say that when it comes to the decisions that are made, they tend to lean more towards the business actuarial aspects. Okay. So if you have brilliant HEOR data and you show that, but at the same time, your cost might be a little high, chances are it's probably not going to pan out too well for you, unfortunately. I think we're definitely moving in the direction where HEOR is taking more of a seat at the table, and payers, PBMs are, more receptive to that data. But I think right now, it's really about these hard outcomes. And if you have anything on the back end, say something like a quality of life indicator or something like that, that's definitely more of like a cherry on top at the present, gotcha. Unfortunately.
That's interesting. I like how you describe that these large organizations are actually kind of made up of people. And because that was one of my questions. I'm just genuinely curious, like, who is typically the counterparty in these kind of conversations? Is it a business person? Is it a doctor? Sounds like it's a little bit of both. But there is gonna, at the end of the day, always be that like profit or business prerogative. I did want to dive a little bit deeper into these hard outcomes you describe. Are these things like, cardiovascular events, or like, the typical clinical outcomes that you think of when you think about, does a drug work or not?
Yeah, absolutely. And so, you'll hear the term like hard outcomes thrown around a lot, particularly in the outcomes or, HEOR or access space. And what these tend to be are things that are going to save the payer, the PBM, money. Okay. So these are things that you can directly show them, and you can say, if I give you drug X, which costs $100 a year, I'm going to save you $1,000 a year in hospitalizations alone. And so that's kind of like the idea behind this whole hard outcomes approach. Now, the part where it gets really interesting is that we kind of live in a fragmented ecosystem. So not everyone cares about everything. And what I mean by that is a lot of the time, if you're doing any sort of negotiation for drug benefit, you're going to be dealing with a pharmacy benefit manager. So a PBM, as you'll hear them all the time. And the hard part about this is that they, there's probably 4 to 5 of them that are making up 80 to 90% of the market share in this PBM business. So you're going to be working with them. They have great leverage. They're going to get great costs for their plans, but they have a different set of interests than the plans do, because the plans are going to be paying them regardless. And they're going to be negotiating the benefit for the drug. But if you come to a PBM and you say, hey, I have this drug, it costs $100, but it'll reduce hospitalizations by $1,000 per year, then the PBM says, why do I care? I don't manage medical benefits. So to them, it's very much how can we minimize drug costs? And can we have a drug that minimizes the use of other drugs? So it's kind of this idea, and that's why it's so complicated and fragmented and interesting and ripe for opportunity, because the incentives are so disaligned in some opportunities. So if you went to a health plan and told them, I can save you $1,000, of course they're going to care. But they're not negotiating the drug benefit most of the time.
The PBM.
So that's exactly. So that's where it gets so interesting with negotiations and HEOR data. Yeah.
So I just want to make sure this is funny because this is a topic that is like so confusing no matter how many times you read about it. That's why I'm happy to talk to you about it, because it's more clarifying for me. So the PBM, gets paid by the insurer on the basis of how much drug spend they save the insurer. Is that what it sounds like?
So they're going to pay, based in it. I don't want to oversimplify this by any means, because there are different sort of like contractual mechanisms they use. But for the most part, they're going to basically be paying some sort of like yearly fee. We'll call it that. And so it's basically like a per member sort of fee that they're going to be paying to the PBM. So the money is flowing to the PBM with the expectation that, the PBM is going to negotiate, these drug costs and get a much reduced cost from like the list price. So, whenever you see these like hyperinflated list prices, that's not what the PBM is paying by any means. And oftentimes it's like a 50 or 60% reduction. And if you look in like really commoditized disease states like diabetes for insulin, you're talking about like 70, 80% discounts off of the list price. So that's kind of the expectation for the plan to the PBM, is that they're going to get these crazy discounts and they're going to pass along savings for the most part to the plan. But what the PBM, again, doesn't really care about is what are these hard outcomes doing to the plan members. So the plan is able to say, PBM X was able to get us a great deal on this drug, but PBM X never really cared about, what are the hard outcomes on that drug to the plan. They kind of care about, what's the bottom line here? What can we work with?
Gotcha. Does that sort of incentive structure, how does that affect the way that the drug manufacturer negotiates with the PBM as far as like their list price and their discounted price? I sort of heard an argument before that incentive structure that you described can sometimes cause like drug manufacturers to have to inflate their prices only to like knowingly discount them later. And I like don't understand this at all. So is that accurate in any way?
Yeah, no, so that's completely accurate. And so what I would say there is that we kind of live in this system right now where a lot of the revenue that comes to PBMs are going to come in the form of manufacturer discounts. Okay. So I think what a lot of people don't understand is that it's not a discount in a traditional discount sense. So if I was going to sell you a drug for $100 and you said, no, I'm going to take that for $10, I think the most appropriate thing for me to do would be to say, okay, it costs $10. Just give me $10 and I'll give you the drug. But that's not actually how it works in the PBM space. So how it works is actually a rebate. And so I think that a lot of our generation doesn't really know like what rebates are, but I think that a lot of like older products, if you bought them, they would offer like a rebate or something like that. And so what it really means is that you're getting money back later. So you're not actually getting money at like the point of sale. And so what that drives is that, PBM X is going to get that drug. They're going to pay $100 for it. But, at the end of the quarter, they're going to get back $90 from the manufacturer. And so what that means is they are actually getting money in their pocket, and then they're kind of passing along some of the costs of the plan. So they're getting a lot of revenue to be able to fund their business. And so we live in a system right now that really incentivizes those high list price, high discount products because they pass so much revenue along to the PBMs. But we are moving, thankfully, into a system that's a little bit more equitable to products with the list prices and discount products or discount prices that are kind of like more in line with what we would expect. And again, I think if we go back to this example of hepatitis C again, you can kind of see these like misaligned incentives at play because you have drugs like Harvoni out there, which is, a blockbuster HCV product, high list, high discount, very popular with PBMs. And then AbbVie comes along and releases Mavyret. So Mavyret was, this product that was competing with, Harvoni, which was, $90,000 list and maybe like $50,000, $40,000, $30,000 after discount. So Mavyret was a list price of about $30,000. And that's what they offered. So they basically offered this, we're going to have this drug. It's going to be a list of $30,000 and we're not going to discount it. Take it or leave it. And what ended up happening in this whole, case study is that they got very, very little uptake from PBMs right away. And I think the first year after they released, Express Scripts, which is one of the biggest PBMs out there, actually excluded them from formulary. So they basically said, we're not getting any rebate from you. We don't want you on formulary. We don't want you to be used by our physicians. No one on our plan. We're not going to use you. And so I think that that's, a great example of what happens when you try to be a little bit cavalier in a system that is so entrenched in a certain misaligned way of working. And what I would say is kind of moving forward, you're kind of seeing a little bit more of these like transparent PBMs is kind of what they want to be viewed as. And so these PBMs are definitely more, they're getting fees for data, flat rate fees for different sort of contracting for the plans, and they're not actually taking in a lot of money from rebates. So this, I think, is where we're going to start to see the industry move over time, is that PBMs are not going to be driven by rebates and more so just driven by flat rate fees. Okay. And I think that will create a system that will kind of get to tamper down this bubble that we have of this like, and you'll hear this phrase or saying every now and again, but it's called the gross to net bubble. Okay. And basically what it means is that we're just in this bubble right now where you see these super inflated list prices, but when you break it down, it's maybe a fifth of the actual cost is what the drug truly costs. So we are in the midst of this like gross to net bubble. And I think that PBMs kind of moving their incentives away from that high list, high discount will push us into a more equitable place for everyone when it comes to healthcare, particularly because, obviously the PBMs are paying that discounted price, but if you're a patient going to the pharmacy to pick up one of these, super inflated gross to net drugs, your co-insurance is going to be based on that list price, not the discount price.
Gotcha. So your out-of-pocket costs might not necessarily go down with that discount, with those discounts going up, right? Like as the patient.
Exactly. Yeah, the PBM is going to negotiate that rate. They're going to pass some of the savings along to their plans. But if you come to pick up that drug that's $100 and you have a 20% co-insurance, particularly if you're on, a specialty tier for that particular drug, then you're going to be paying $20. And if that drug is $10,000, then you're going to be paying $2,000. Even if the PBM is only paying $1,000 for that $10,000 product. And that's kind of where we get into the situation of, there are a lot of things that are kind of at foul when it comes to the access space. And that's, again, why I mentioned that it's just kind of like ripe for opportunity to disrupt these systems that are at play right now.
Yeah. That's unfortunate that situation you described. I mean, the patient kind of gets like left with their hand out. You mentioned this example of Mavoret sort of like getting, I forget what the formulary was, but getting kicked off of a plan for that pricing scheme. And I think I kind of had an aha moment when someone just described to me like the sheer size of some of these networks or these payer plans. I don't know if you have any numbers, but I mean, when you aren't on one of these plans, these are like the size of entire European countries, right?
Yeah. I mean, I think that, Caremark, like CVS Caremark is one of the biggest PBMs that play right now. And I was actually just looking at this today. I think they have around between like 55 to 60 million lives that they cover. Okay. So what that means, and then like the so what of that is that if you're a manufacturer and you're making a product and you want it to be covered, if you don't get that coverage under CVS Caremark for the PBM, you have effectively blacklisted yourself from about a sixth of the US population. And that's, one of four big players there. So you have to kind of tread lightly because these companies are so leveraged with the amount of patients that they have. And again, that's why they're able to get like the discounts that they can, because, at a certain point, if they're saying, 50% discount, take it or leave it, or else we're going to exclude you from formulary. If you're a young manufacturer and you have, shareholders to report to, you can't come back to them and say, we're blacklisted from like a sixth of the market right now. Like that's just not going to fly. So you have to take that discount and just go with it.
Yeah. I mean, thanks for clarifying that. They just have tremendous leverage and power. And they're just like, private companies. Really, really interesting. So I do want to sort of, actually, before I kind of do transition to the chronic kidney disease space that you work in, and I wanted to ask you some questions about that. I am curious what some of this, you mentioned some of the problems with the system. I'm curious what some of your sort of ideas for opportunity, this ripeness for opportunity that you mentioned. Like, where do you think some of the improvements will come in the next 10 to 20 years?
Yeah, so that's a really good question. And I wish I had all the answers. So I'll just kind of give like a eye in the sky sort of idea. But yeah, I think that, it's kind of mostly like a talk situation right now. I think a lot of people talk about like value-based care, value-based contracting and things like that. I think that one of the areas that I would expect to see grow and really make a difference in the industry over time is going to be any sort of, payer PBM, or maybe even like a middleman that can kind of standardize this value-based contracting side of things, and turn it into something that's not just kind of, a hand wavy thing to say, we're a value-based organization, but we've essentially structured this contract to look essentially exactly like our other ones. Okay. And I think that's what you'll find a lot of the time, is that the risk is really important when it comes to these value-based contracts. And it really depends how you kind of turn that knob on who is more at risk, because someone is going to lose in that agreement, whether they want you to believe it or not. Either the manufacturer is going to get screwed with the contracting terms, or the payer is going to get screwed on the contracting terms. And I think that, these value-based contracts give a little bit of, a little bit of like a ceiling and a floor to work with in terms of the risk, but someone is ultimately going to lose.
Yeah.
So I think that, an area that is really ripe for opportunity there is just some sort of company, some sort of organization that can standardize those value-based contracting decisions, because as of right now, companies really don't have the capability to do it. They don't understand what sort of outcomes are important. They don't understand how to measure the outcomes. So if there's any way for a company to integrate with a payer to get that data that they need to work with the two to independently come up with terms that are, equitable for both of them, and to be able to do it at a cost that's fair, I think that that's an area that should grow over time, and one where I would really, hope for it to grow over time.
Yeah. Yeah. I mean, I hope so too. And it's interesting the way you describe it, and the way I've heard it being described is it's like, it really is one of those, I don't know if zero sum is the right word, but where one person's, cost is another person's revenues. And it's just like, it's just sort of an interesting thing, because it basically comes down to who has more pull. Yeah, so I want to talk more about, it's kind of funny, like some people refer to these things as market access, as we described it earlier, and other people say patient access. And like, is there a difference? And is it just terminology? Isn't the patient the market ultimately, in terms of the final user of these pharmaceutical products?
Yeah, and that's a really good question, and a good distinction as well. And I think that, for the most part, I think you'll hear a lot of people just say access when they talk about this like functional area. And when they're talking about market access, I find that, oftentimes it's dealing with like the formularies and things like that. Patient access tends to be more like patient access programs. There's like copay programs, patient support, free drug, bridge programs, things like that. But like ultimately they, fall under the same wheelhouse of, we're trying to get patients on drug. It's kind of just like a different perspective of, am I trying to flip the switch on the market, or am I trying to flip the switch on a patient behavior,
Okay. So what are some examples of ways you like flip the switch on patient behavior?
Yeah. And so, I mean, this is like one of the things that I got to do pretty frequently at my last job in consulting is, what is like the patient psychology and behavior, and how do you influence that from a manufacturer's perspective? And, one of the things that's really cool is that, patients are, for the most part, like any other rational consumer, they have price points, and they have, for the most part, pretty elastic price points when it comes to when they're going to buy and when they're going to walk away from it. Mm-hmm. And so it's kind of the manufacturer's job to figure out, what are those price points we have to work with. So I know we talked earlier about co-insurances and things like that. If we find out that a patient is getting a $100 drug, and their copay is going to be $10, and let's say this patient just really does not want to shell out $10 for this prescription, they're going to walk away from it. And so that manufacturer is going to be able to potentially see, if they have data coming in, that this patient came in, they saw a price of $10, and they walked away from it. And so this is kind of the aspect of where data comes into these decisions is, we have so much data around claims, and you'd be actually very surprised to see what sort of data comes in for claims data. And we can kind of understand what sort of process that patient went through in each step. And, did they see the price? Did they get the price lowered with some sort of copay program? And if that lowered price, did they, pick it up, or did they walk away? And so if you can find out somehow that lowering that price for that patient will make them pick up that drug, that's really valuable information. And what's more valuable than that is, if you're a manufacturer and you understand, if we lower the price point, they're going to pick up the drug. So if you're a non-data driven organization, you're going to say, okay, that patient had a $10 copay, make it $0. That patient's going to pay $0. Mm-hmm. And so, a lot of these patients are going to see that $0 price point, and they're going to pick up.
Yeah.
And what the savvy manufacturer can do is they can say, we found the price point at $6, And that's the price point at which most patients walk away. So
Okay.
if we can get most patients down below 6, then we're still going to keep the patients that we want to keep. And at the same time, we're not going to be losing $6 on every prescription.
Mm-hmm.
And so, this is kind of, again, where that clinical aspect meets that more business aspect. Obviously, you want those patients to get on therapy because they need the therapy. But at the end of the day, there is a business aspect to it, and there is an ROI, or return on investment aspect, that you have to keep in mind when it comes to these programs. Some of these programs are just bleeding money, and some of them are actually really good at making sure to keep patients on while staying very sustainable over time.
Mm-hmm. Is there any aspect of like patient assistant programs, and maybe they're different than patient access programs? I think you've brought up several examples of where the terminology is not standardized, and who knows what means what, but you kind of have to use context clues. But I mean, is there any aspect of patient assistant programs that doesn't necessarily have that business aspect in mind, like where they're just giving away free drug to patients who can't afford it, for example, in certain circumstances, maybe more of a charitable cause? And I know these things exist, but I guess how do they decide when to do that? Is it just a certain amount they allocate each year? Do you have any insight onto those free drug programs that companies run?
Yeah, so I think it's a good question. I think that a lot of the patient programs you'll see out there, they tend to have some sort of aspect of like free drug, and that tends to be for more underinsured or uninsured patients. And typically what you'll find there is that they look for, is this patient below like the federal poverty line or something like that, at which point, that patient may be getting free drug. And so that's one of those aspects there where it is, technically like charitable. And the aspect that I would definitely like add there is that, these companies are going to be taking that, some percent of drug that's given away is free. They're probably going to be considering that in their pricing. So if, you have a list price of X, but you're going to give away, 5% of your product for free, as a manufacturer, you're probably going to up the original list price by a little bit to account for the fact that you are going to be giving away some percentage of the drug, like absolutely for free.
Gotcha.
The other aspect to like free drug programs, and you'll hear them called like bridge programs every now and again, is like a little bit less charitable in the way that it works. You'll find that like manufacturers will give out free product for like a set period of time, say like a month or 2 months or 3 months, or even up to like a year in some cases. And the idea behind those is that they're typically newer products, like they've just hit the market. They're trying to get patients on drug and to get them as consistent patients going forward. But what they're trying to do with that strategy is to get the patients on and hope that they're going to get insurance coverage in the next year or so.
Okay.
So at that point, you're kind of building up your own leverage as a manufacturer to be able to go to the payers and say, you already have, say 10, 20,000 patients on this product. You really need to cover it.
Yeah.
Otherwise, these patients are going to be, without the product because we can't keep this bridge program going.
Mm-hmm. It's like a free sample at Sam's Club or something.
Exactly. Yeah.
Now it's time to buy the whole box. Okay. Well, that's it for today, Sam. Thanks so much for joining us. I think there's so many different aspects of this area, just access, pricing, pricing for whom, because there's so many different times where dollar bills seem to exchange hands in this market. And I think just talking to someone like you helps to clarify a lot of the information that you read online or in a book or what have you. It just doesn't make sense until you hear it explained by someone who knows what's going on. So I really thank you for that. And yeah, anything else you wanted to say?
No, I mean, thanks again for having me on the show today, Mo. I think this is an awesome opportunity, and I think that you're going to get a lot of guests because your questions are really insightful and get us going. So thanks again for having me on, man.
Oh, thanks. I appreciate that so much, man. And it's been an honor. I hope to have you on again. Hey, everyone. Thanks for listening. I hope you enjoyed the show. I hope you learned something from Sam, as I always do. Please check out the show notes for all the relevant links, and don't be afraid to like, share, and subscribe. Okay, now, take care.